So, coming to the topic, it's a very vast topic. So, what I have planned is, in a way, to squeeze it. Like we crimp a valve, we have to try to crimp the whole topic in a couple of slides. So that gives an idea to the young surgeons who are aspiring to get into structural heart, or who have just started, or those who intend to start it. So how to plan a case, if any surgeon wants to plan. Basically, every surgeon has a comfort zone. We too have, for that matter of fact, but we have to come out of it because we are used to big incisions. We see everything. We have time-tested techniques. We can manage everything when we have everything in front of us, open in front of us. Complications can be managed very easily. But obviously, we have to come out of the comfort zone and, getting into a new arena. We have to readjust. We have to relearn. We have to unlearn some things. And here we have some wiring techniques. We have visualization on the screen, doing things on the groin or on the radial or whatever is our access point. Indications are basically standard, very high probability risks, high and intermediate risk patients with high ST score, frailty index, patients who are quite frail, low risk patients. The trial is underway. Time will tell, and probably they will start doing it in low risk patient as well very soon. Obviously, age 70 to 75 years or more, but at times it's patient's choice. I have put in TAVR in a 52-year-old lady because she never wanted any cut. So obviously we have to offer. ST score less than 4, certainly you have to consider SAVR or suggest SAVR. Why planning is important? Because it is 90% of the job done well. Echo is very crucial in overall planning. Good echo is very important. And it is usually very important when you have a patient in whom you have to avoid contrast, especially with CKD patients. TEE may be required in these patients as well, but rarely it is needed in routine patients. But it can never replace CT scan in planning. So these are just a list to complete about aortic valve indications, and 3 basic categories, which what we all know: low flow, low gradient, normal flow, low gradient, and high gradient. And coming to the assessment on echo. Basically, annulus is a dynamic structure which is more elliptical during systole, and any linear measurement of the annulus is bound to undersize or oversize. So perimeter is something which remains more or less constant during the cycle. So the measurement of the valve is more or less based on calculation of the perimeter. That too can change. That too usually changes 10 to 15%. So we tend to oversize the valve at the tune of 15 to 20% when we choose the right valve for the annulus. Also, when we are going to put the valve, we are actually creating a new geometry, which is more circular. Now, coming to CT. CT is the gold standard, and contrast CT. It's operator independent. Rapidity of acquisition as well as remote analysis makes it a very good tool. There are 3 basic softwares, of which 3Mensio is the most commonly used one. DICOM is also used, but then we have never used anything else except this 3Mensio. And the newer machines, with newer machines, you can have very small amount of dye, as less as 50 ml, with these kind of dual source CTs, which have very high spatial and temporal resolutions. And they have practically eliminated the need for angiography of excess vessels. Now, as we discussed, the measurements are done in systole, and there are 2 techniques which are used during CT. It's basically retrospective ECG gated and prospective ECG triggered to avoid motion artifacts. As I've already told, there is increase in 10% to 15% of area in perimeter as well. And there is something which is called aortic valve complex. It is the structures which are between left ventricle outflow and the aortic tube. Everything lies there. You have to analyze the whole aortic valve complex, which all consists of morphology. Is it tricuspid or bicuspid? Single raphe, double raphe, or there is no raphe at all? Size the annulus, sinus room, STJ heights, coronary heights, calcification on the leaflets, LVOT. Is there any spur on the LVOT that might, increase the risk of PVL, PPI, root injury, sometimes pop out? Quantity and distribution of calcium is also very important, especially in the landing zone. The idea of deploying the valve is as shallow as possible. It has to be 3 to 4 mm, best is 3 mm. Now, the problem is if you implant higher, there are chances of PVL. If you go down, there are chances of PPI. So you have to keep a balanced approach, and it depends on patient to patient and the CT analysis. You have to know the aortic angle because strategy can change according to the angle. If aortic angle is more than 60 degrees, it's more of a horizontal aorta. Then your approach going inside, taking a different valve delivery system might change your whole strategy. Coronary heights are important because you have to plan your coronary protection strategy in advance, whether to do it preoperatively or to do at the time of procedure, what strategy you have to do. This is actually the aortic angle, which is basically the annular plane from the horizontal plane. Now, imaging can help you decide the valve platform, depth of deployment, angulation if required, and to avoid contour injury wherever there are calcium spurs in the LV outflow, or to consider alternative approaches like transapical, transaortic, sometimes axillary, carotid, or transcaval. You need to know a little bit about your valve as well. Basically, these are trileaflet valves, can be bovine, porcine, or at times under research, some polymeric material as well. They're mounted on radio-opaque metallic scaffolds. It may be stainless steel, nitinol, or cobalt chromium alloy. There is basically an inner sheath and outer sheath. Outer sheath is something which anchors the valve into the annulus. And there are changes and the research going on in designing different sheets with some gels also. Newer valves are coming with better and better anchoring mechanism that lead to low chances of PPI and less chances of PVL. These are two commonly used valve platforms. These are self-expandable valves and balloon expandable platforms. Others are mechanically expandable, which have a separate mechanically deploying system, which can go from top, bottom. And there are some valves which have got active fixation mechanism. These are especially being developed or are being used for aortic regurgitation or the valves where there is no calcium at all. Now, coming to self-expandable platform, majority of them are supraannular. They give higher effective orifice area because the actual valve is above the annulus. It is flared, and they are better for small annulus, valve in valve, and usually they don't require rapid ventricular pacing, which is normally required during deployment of the balloon expandable systems. Most of them are recapturable, repositionable. Actually, you can implant the 80% of valve and take your time and decide, or recapture it again and deploy it again. You want to go shallow, you want to go deep. So they are particularly indicated in patients with small annulus, as I told. severely calcific annulus, valve in valve, or a very small bioprosthetic valve. Like we did one patient, this patient had a trifecta 12 years back, and that too 19 size. And trifecta is a valve which cannot be fractured very easily, but it can be fractured with a non-compliant balloon, that is Atlas balloon only. This is the only balloon which can fracture this valve, but that too can be disastrous at times. It can lead to root injury. So in this patient, we had this self-expandable valve, and we got area of 23. Now, these valves are bigger profile. They have higher frame height, so that comes with a disadvantage. They may have high rate of PPI because they work on the radial force of expansion over time. And because of the big cage, which comes in front of the coronaries, future coronary access may be challenging as compared to the balloon expandable valve systems. The available systems are Medtronic's core valve, Accurate Neo, which comes from Boston Scientific, Allegra, Hydra, which is being developed by an Indian company, Engager, and Centra. Now, come to balloon expandable valves. This is another major, Edwards comes with it. And in US, they have 70% of the market. They were the first valve implanted. And they are intra-annular. They are not repositionable. Deployment requires rapid ventricular pacing. They have a smaller profile, stent frame, and coronary access is definitely easier as compared to self-expandable valve. Furthermore, they have a very big advantage that their delivery system has got steerability that can negotiate the acute curves of aorta when we go from arch to the ascending aorta. So they are particularly advantageous in situations where the aortic angle is more than 60 degrees. But there are some disadvantages that many patients with poor LV function, impaired renal function, these patients may not tolerate rapid ventricular pacing very well. So Sapiens is the most common valve, my valve, Merrill, which comes from India and company. Mechanically expandable valves are there. And as I told that there are some valves which have got active anchoring mechanism. They are metallic spurs which come out and they anchor actively into the annulus. They are basically made for aortic regurgitation, like Jena valve is there, JC valve is there. So these are a couple of valves just to show you. Now, the delivery system basically a sheath. Initially, they started with 24 French. Now, the usual size of these sheaths is around 14 to 16 French. And with the Edwards, they have a flexion mechanism at the distal end in the balloon expandable valve. Now, what valve to select for your patient? For most type of patients, I think Evolute and Sapiens can be chosen, but they may not still cover the full range of requirement of the anatomy or the annular size. So there are many issues which can influence the choice of valve, like if there is high risk for annular rupture, patients who are very small, annulus is very calcified, a self-expandable rather than a balloon expandable valve may be chosen, as annular rupture has been observed most commonly with balloon expandable valves as compared to self-expandable platforms. Also, if there are concerned about coronary obstruction, if coronary heights are low, you have to rely more on self-expandable platforms, because once you deploy, you have still got chance to recapture again and redeploy it again. Patients who are at high risk of block, like those who have RBBB, so you can go for balloon expandable platform because the chances of PPI are less. Or when you are choosing valve in valve, because valve in valve is something which is going to come to surgeons back again in future. So this is going to be our territory. So we have to be very particular about patients who have got bioprosthetic valve, and we are following them in future. Also, there is very important thing. There are at times there are spurs of calcium in the LV outflow that can affect your deployment. Sometimes you have to deploy a little valve at a little angulation to avoid counter-coup injury or to avoid major PVL. See, the whole idea doing first case or initial cases is that patient should go home without any complication. Good clinical results. So what valve you have to choose, what anesthesia you have to give, what access you have to choose. So these are the common questions which will come in everybody's mind. Heart team is very important. Probably what, as a surgeon, I believe heart team is very important for cardiologists, but not for surgeon, because surgeon in itself is a heart team. So it involves clinical assessment, echo. You have to decide about the coronary artery disease, what you have to do. You have to get it corrected beforehand or at the time of procedure or later on. And nonetheless, CT scan planning. Now, hardware is very important. Everything is hardware in the cath lab. You need to have all the hardwares, plan A, plan B, plan C. If this goes wrong, what will you take next? If this goes wrong, what will you take after that? So you have to have all the wires. You have to have knowledge of all basic wires, basic catheters, balloons, closure devices. You need to have peripheral cannulation set in the cath lab. We have a patient on which we had to go on ECMO for a short period of time because patient, even after CPR, she didn't came. So we have to initiate an ECMO and manage her for 15-20 minutes, but then patient was revived and luckily she was saved. Nowadays, it's all minimalistic approach, percutaneous. Since the device profile is very small, 14 French, sometimes even one single ProGlide and angioceal is enough. That will suffice. But it's always safe to use 2 ProGlides. That gives absolutely good sealing, no bleeding at all. And nowadays, there is trend towards not using the other groin rather than going through radial for secondary access. Secondary access means doing shoots, marker pigtails, and anything in adjunct you have to do along with TAVR, or you have to do angioplasty also at the same time. And normally we use conscious sedation only. Now, coming to excess vessels, it's very important. Normally, right groin is our index groin. And the minimum size, what is acceptable is with core valve systems, it is 5 mm. With Edwards Sapien system, it is minimum 5.5 mm. Below this, you have to consider alternate access, or you have to open it and dilate it. We have done that also. So that works, but only with surgeons. Ultrasound it's always a good idea to use ultrasound as an adjunct to taking an access. In fact, it's always better to take left sheath, wire from the left side, do a DSA, do an angio, and find the best spot just below inguinal ligament in front of femoral head, and then take the right access. Because device is bigger, so you need a good soft spot to enter. This is just a picture to show you the stretched out aorta with iliac. Given all the access are good, right is usually the index groin. Left groin is usually used for marker pigtail and at times radial, as I've already told. At times you can use brachial as well. And for initial cases, you use general anesthesia and cut down at the groin. Now, how we proceed? First step is to take left femoral access, whichever way you want. Then take right access, under vision under the fluoro, doing a DSA. There are different catheters, different choices of catheter for different people. What we use is usually JR and Lima. That is always best to give you the curve to get into other side. First is to dilate and put 2 ProGlides. Then take a marker pigtail from the left groin and you go all the way into the aorta and house it into the non-coronary cusp. That is the standard technique to start with. And take a shoot over there. And there are, again, different choices. Commonest is, and the easiest is to take a multi-purpose with a soft tip catheter. That has to be exchange length, because exchange length is 260 centimeter, so that any catheter can be exchanged on that. Root angio is done, coronary angio is done, if not done previously. Coronary protection strategy is to be defined at this time. There is a software which can tell you VTC, virtual transcatheter valve to coronary distance, which can actually predict the coronary obstruction or impingement. So you can always plan all these things in advance. It is not to decide on the table, but sometimes it can happen there as well. So, I mean, where to do all these things? You know that coronary heights are low, sinuses are not roomy, or they are deficient or sequestered sinus. You need to have, this is must, balloon tip TPI. This is to be put from the right groin, from the femoral vein. We have one patient in whom we had RV ruptured because of we didn't have balloon tip TPI. We said, okay, chalo, let's do it. So this is must. And before doing anything, check the pacemaker. Now, if coronary has to be protected, now you have to decide what you have to do. Chimney or snorkel or leaflet laceration. These are rare. Leaflet laceration actually very rare. We don't do that often. But yes, chimney is a common strategy. Now, a very important, or I must say, unpredictable step initially is crossing the valve. How you cross the valve. You know, that sometimes may take very long time, sometimes even 40 minutes, 45 minutes as well. That is something which we have to learn over time, and that comes with experience, expertise. And there are different techniques. They have been advised by the experts. Commonest is usually we take implants with straight tip Terumo. Try and move LAO, RAO, AP, and somehow you understand that where is the orifice and you negotiate through the orifice. There was a recent study where they have used pigtail with J wire in 30-degree RAO and turning it in a particular direction, and then that tip of the pigtail opens in front of the valve. So they say that has got the shortest possible time of crossing through the valve. All the wire have to be exchanged. Take a pigtail, cross through the LV, and do the shoot again and do the gradients. Check the gradients. Decide whether you have to pre-dilate the valve or not, or you have to go straight with the delivery system. Now, when you need to pre-dilate, if the gradients are very high, there has been very difficult, or you have faced a lot of difficulties crossing the valve, it took time, probably then it needs pre-dilatation. Or sometimes when you have taken the device and you are not able to cross the valve, you don't push so much so as to injure. It's better to take out the device and pre-dilate and then go ahead. In these patients, self-expandable platform may be preferable. And while pre-dilating, if the coronary heights are borderline, it can give you idea of any coronary impingement as well. Or you can see ST changes on the screen. So this is actually with with time constraint. I don't think we need to go into the detail of these algorithms. So basically, when we have crossed the valve, the next step is to take the stiff wire, because the stiff wire is very important, because the whole delivery system has to travel on this wire. There are two common stiff wires which we use. Is either one is Safari and one is Confida. Safari comes from Boston and Confida is from Medtronic. Now, implantation angle is pre-decided on CT planning. So you have to put the patient into implantation angle, fix the table. What projection you have to use? It depends on the kind of platform you're going to use. There are two basic projections used for deployment. 3 cusp coplanar view. That is usually best for balloon expandable valve and cuspal overlap. I'll show. Yeah, this is, if you look at this carefully, this blue thing, do I have a pointer? That blue is basically the II, image intensifier. If you look at that, when you put all 3 cusps in one projection, that's actually the 3 cusp coplanar view. You can see all the 3 cusps in line. RCC in the middle, LCC on the right side, left side, and NCC on this side. This is 3 cusp coplanar view. It is usually used. Wind up karo, kyunki 12:30 baje mujhe dusra lecture karana hai. Now, cerebral projection, which is actually not very common, but at times when we have a lot of calcium, when the aorta is horizontal, or you have done, you expect that you are going to pre-dilate or post-dilate the valve multiple times, then it is probably a good idea to go with it. So I'll just go across the new devices. Sentinel CPT device is basically the commonest one, which is used nowadays. This is how this device is put. You go all the way from subclavian, and there are 2 funnel-shaped filters. One deploys in the common carotid and one in the innominate. Now, I mean, take-home message, basically. Every day, there is something new coming up in transcatheter techniques and the valves and the design. Now, newer skirts are being developed to minimize the chances of PVL. Newer closure devices are coming, which can, a single device can work for whatever large profile of device you have. You have to go through excess vessel. Intravascular lithotripsy, what cardiologists can always help you with. If you have bad calcium on the excess vessel, still it can be done. It can be used. Now, for all the surgeons, I must say, have you missed the bus? No, never. And it's never late to start it. And sooner or later, tricuspid device is also coming. Cable valves are already here. So all the valves are going to be done by catheter techniques. So we have to get on this bus as soon as possible, whether we like it or not. Thank you.